Hello and welcome. My name is Devin Kibani. I'm an EM physician with the University of South Florida, and today I'll be talking about POCUS for fluid responsiveness. This talk focuses on using ultrasound to answer a very specific question. Will this patient increase their stroke volume if I give fluids? We are not asking, is the patient dry, but rather where they are on the Frank-Starling curve. So POCUS allows us to shift from a static surrogate of volume to a dynamic assessment of flow. By the end of this session, I hope you'll be more able to clearly distinguish fluid tolerance versus responsiveness, and we'll cover dynamic versus static assessments, learn how to perform Carotid VTI, LVOT VTI, and corrected flow time. And as a bonus, we're also going to learn how we can measure cardiac output with these fancy new calculations that we're going to learn. And ultimately, our goal here today is to understand how this all integrates into improving care of our critical care patients and improving hemodynamic decision-making. Yes, the Frank-Starling curve. We have all seen this at some point of our training, but as a refresher, early on in the curve, small volume changes will result in a large increase in stroke volume, whereas later on in the curve, any additional fluid results in most likely minimal cardiac output with more of a risk to the patient. So the key question is, where is my patient now? This is more of our area of interest. We are looking to see how a patient will increase their stroke volume with an increase in preload, and how we can use POCUS to visualize that. So again, fluid responsiveness is not really whether a patient needs fluid, but whether they lie on the part of that Frank-Starling curve where fluid will increase their stroke volume. So let's get into how POCUS can help us with that. Some findings on ultrasound that are more consistent with likely being fluid responsive would be things like a small collapsible IVC, probably a hyperdynamic left ventricle, and what we'll be focusing on today, how a passive leg raise will increase a VTI and carotid flow time. Findings that are suggestive of non-responsiveness would be plethoric, non-collapsing IVC, a normal or large left ventricular end diastolic volume, left ventricle that is likely not hyperdynamic, and again, how a passive leg raise test, conversely, would not show an increase in VTI or carotid flow time. So static tests will tell you what preload looks like, whereas a dynamic test tells us what happens when preload changes and how we can directly assess movement along that curve. What we mean by dynamic is that we're adding in a challenge, such as a passive leg raise or a fluid bolus, and measuring the real-time physiologic response using ultrasound to determine a patient's volume status. Today, we'll be focusing on a passive leg raise as our physiologic challenge. Some static tests that we may be more familiar with, like assessing the IVC for its size and collapsibility, the overall interaction between the left ventricle and the right ventricle, and the global echo function itself, like ejection fraction using EPSS measurement. But these do not predict responses reliably. They provide context, not answers. So we think of static data more as background information. So lung ultrasound answers a different question. Can this patient tolerate more fluid? As a refresher, B lines are bright vertical artifacts that extend down from the pleural line, whereas A lines, as seen above, are bright horizontal artifacts that extend from the pleural line. As part of the complete assessment, you should scan the lungs to assess for markers of impaired tolerance, for example, an increase in B lines that would suggest potentially pulmonary edema or other processes that may deter us from giving more fluids. So we integrate cardiac and lung findings to decide whether fluids are both useful as well as safe. IVC ultrasound can be helpful, but must be interpreted carefully. We start with an overall visual assessment of the size and collapsibility or desensibility, where a thin collapsible IVC, seen here in the top image, IVC being this vessel here, dumping into the right side of the heart. A thin collapsible IVC would suggest low right-sided filling pressures, whereas on the bottom image here, we see the same vessel entering the right side of the heart, but conversely, we see this large, distended, plethoric IVC that does not change much with respiratory variation. This would likely be more suggestive of higher right atrial pressures or impaired venous compliance. In spontaneously breathing patients, we measure collapsibility. Around 40 to 50% collapse suggests potential fluid responsiveness. Whereas in mechanically ventilated patients, we more often measure distensibility, and an 18% distensibility is commonly used as a threshold. But remember, IVC measurements are affected by abdominal pressure, RV dysfunction, obesity, ventilator settings, vasoactive medications. So again, IVC is really being used as a contextual tool, not a decision maker. So getting into more of the meat and potatoes of our lecture today, the dynamic tests. These are some of the core tests we're going to cover. Carotid and LVOT VTI with a passive leg raise, and assessing change in the corrected flow time with passive leg raise. And we're going to show how adding in a passive leg raise with these measurements help us determine whether stroke volume is going to increase with preload, which defines fluid responsiveness. So the reason why we perform passive leg raise is because it mobilizes around 200 to 300 milliliters of blood from the venous reservoir of the lower extremities to the thorax. So doing this increases our venous return and thus challenges the Frank-Starling curve. We choose this over giving a fluid bolus because this preload augmentation is reversible. However, it is also transient. So when we are performing this test, we need to assess the hemodynamic response within 30 to 90 seconds after performing the maneuver. So if you're wondering, how do I perform this passive leg raise while also obtaining cardiac or carotid artery measurements with the ultrasound, I added this nice little picture to show you how that is done. It's pretty feasible to be done all at the same time. Sometimes requires help from a friend with the passive leg raise component. So the steps itself, you're going to place the patient in a semi-recumbent position with the head at the bed at 45 degrees. You're going to obtain your baseline VTI measurements, which we'll learn soon, whether that be carotid or cardiac. Then you lower the head to the supine position, identify your area of measurement on ultrasound, and begin to run your pulse wave Doppler. Then you'll have an assistant raise the patient's legs to 45 degrees and hold the legs in that position. You'll obtain your VTI tracing within 60 to 90 seconds of the leg raise, freeze the image, then return the patient's legs back to the starting position, and you'll measure the VTI from the frozen image. So introduction to VTI, starting to get into what are we going to be talking about today. VTI is the velocity time integral. It represents the distance that blood travels in one cardiac cycle, and we are utilizing it because it acts as a surrogate for stroke volume. An increase in VTI, whether that be carotid or LVOT, after a fluid challenge or passive leg raise, is a marker of preload dependence, meaning fluid responsive. The main point here being we are tracking change over time or in response to a physiologic change. So the common carotid artery is used as our peripheral surrogate for the heart's outflow. And just of note, a healthy person's VTI can vary. So we're going to focus on the dynamic change, or the delta VTI, rather than absolute numbers to assess the fluid status. Again, we're tracking this change over time after a physiologic manipulation. The advantages here being that it's non-invasive monitoring, and dressings, lines, and vent settings that can oftentimes impair the subcostal like cardiac imaging for performing an LVOT VTI aren't really getting in the way with carotid VTI. It's also less dependent on the Doppler angle than the cardiac LVOT VTI, and the views overall are easier to obtain. Some limitations could include carotid stenosis or arrhythmias. So introduction to the second test that we're going to be learning how to perform, the carotid corrected flow time. This measures the systolic ejection time, which means that we are measuring the time that the heart spends in systole, because in a fluid responsive patient, giving fluids will increase the volume pumped, meaning the stroke volume, which lengthens the time the heart spends ejecting blood, or the systolic time. So we are tracking change over time in response to a physiologic maneuver. We're looking for around 7 to 9% change, or greater than 6 to 7 millisecond increase to define a positive response. These are just a few key points from some recent data that suggest good correlation between carotid LVOT and VTI data, as well as comparing carotid flow time and LVOT VTI data, which showed good, strong correlation, and additionally a meta-analysis that indicated a positive correlation between carotid Doppler and cardiac output measurements. And this analysis actually found that carotid VTI exhibited a stronger correlation than carotid flow time. So now to get into how to perform the carotid VTI, starting with position, probe, and optimization. So what we're going to do is have the patient lay in the supine position, like so. And for probe selection, we'll be using the linear probe. And we'll start by changing some settings on the machine, making sure you're in the linear setting, artery, and carotid. We're going to start with our probe in the transverse position on the patient's neck, identifying the common carotid artery here in the transverse plane. And then we're going to want to rotate the probe with the indicator towards the patient's head in order to put the artery in the sagittal plane. And I show a two-handed technique here that helps you stay on the vessel better. Now, once you have identified your vessel in the sagittal plane, you can see the vein lying on top. We want our vessel of interest in the center of the screen. So to do that, we're going to increase our depth. But then we notice this vessel is laying pretty parallel, and we want a better angle for Doppler angle. So to increase the angle of our vessel on the screen, we're going to rock the probe, so rocking the tail of the probe towards the patient's head like so. And as you can see, that causes an increase in the angle of the vessel on the screen. So once we have our vessel longitudinal or sagittal plane, we have a good angle as well. We can press that pulse wave function, and you're going to see your sample gate pop up with the green angle correct lines extending from that. And you're going to place that in the middle of your vessel, avoiding the walls. So if you're starting to feel a little bit lost on the directions and the angles and the pulse wave and the sample gate, don't worry, let's take a minute, kind of pause for the cause here and do a refresher. So we're looking at the angle between the ultrasound beam and the vessel itself. This is the critical parameter in spectral Doppler because it directly influences the measured blood flow velocity. So to adjust the angle, you'll manually adjust the cursor on the ultrasound screen to align it with the direction of the blood flow parallel to the vessel walls. So in the green line here, this will extend as your angle correct lines, and this is placed in the vessel direction, where this yellow dotted line that I've kind of exaggerated out here is the path of the spectral beam itself. So we are measuring the angle in between the vessel direction or direction of flow and angle correct and the path of the spectral beam. And this angle correction tells the machine the correct value to use in the Doppler equation, and that angle should be less than 60 degrees. Once we have our vessel in the optimal position, we press that pulse wave function, and you start to see this nice spectral tracing pop up with a nice hollow black envelope in the middle. And then you'll freeze your image, analyzing the waveform here, making sure we have a good envelope, good tracing, and then we'll hit measure, carotid, and select VTI. And then we'll drag our cursor to the systolic upstroke at the level of the baseline, tap once here, and then just slide your cursor over to the end of the flow time or the beginning of the next systolic time and tap again, and you'll see your number calculations pop on the left side of the screen and this nice purple tracing, and that is our VTI. So once you have VTI, we'll do carotid flow time next, which is right under. So you'll select carotid flow time. And again, starting at a new waveform at the systolic upstroke level of the baseline, tap there, and then slide your cursor over to the upstroke of the dicrotic notch, tap again. Then returning back to the initial upstroke, tap again, and now drag your cursor over to the end of the cycle, tap again. And as you can see, we've measured the systole time as well as the whole cycle time, and that gives us carotid flow time. So there's the notch, flow time, and our cycle length. Now we are going to make it dynamic. So just a reminder here on how to perform the passive leg raise. So to measure the VTI with the passive leg raise, you start with your patient in a semi-recumbent position. This is data from a patient that we had in the ED who was hypotensive. Their initial VTI in the semi-recumbent position was 18. Then we performed a passive leg raise on the patient, and we actually noted a 38% increase in VTI and a 26% increase in carotid flow time. So as a refresher, our goal was only a 10 to 15% increase in VTI or 6 to 7 millisecond increase in carotid flow time. So how to perform the LVOT VTI measurement. So we're going to start by obtaining your apical 4-chamber view. And then to obtain the apical 5-chamber view, what we do is fan the tail of the probe towards the patient's feet to open up that aortic outflow tract. And as you can see, we have color placed on here so you can see the visual direction of the flow, but that's not necessary. So you can take color off and place your pulse wave gate just below the aortic valve, so on the ventricular side, and placing your angle correct lines in the direction of the flow, hitting your pulse wave function again, and then you start to see this spectral tracing pop up again. Freeze your image, and once you have frozen your image, you select under the aortic package LVOT trace, and then you're going to do just that. You'll trace the waveform with your finger, trying your best to stay on the line itself. And you're going to trace all the way back to the baseline. And once you do that, slide the cursor over to this next cycle, tap again. That gives you your heart rate. And now you've obtained your LVOT VTI tracing here with your heart rate noted as well. And once you've obtained those measurements, go ahead and store that calculation. So now we know how to perform the LVOT VTI. We are again going to make it dynamic. How do we do that, you ask? With a passive leg raise. So this is an example from another institution. They started with the patient in the low Fowlers, which is another word for the semi-recumbent or 45-degree position. Their initial VTI was 12.4. And then after performing a passive leg raise, they noted an increase in the VTI to 18.9 centimeters. So a change by 6.5 centimeters or 52% increase. Remembering that we only are looking for a 10 to 15% increase in VTI. Okay, so now we're going to get into the bonus round, which is how to measure cardiac output using the LVOT VTI. So the measurements that we need are the LVOT diameter, which is going to be the new component I'm going to teach you how to do. And then you also need your LVOT VTI and the heart rate, which we just learned how to do in the previous video. This diagram shows a nice little refresher of the landmarks. So right ventricle, left atrium, and our area of interest here, the left ventricular outflow tract. So step 1 is to measure the LVOT diameter. And you're going to do this by obtaining your parasternal long axis view. And you're going to measure at the base of the aortic valve in mid-systole with the valves open. So placing your cursor over the valve hinges here. And here's a nice tutorial of how to do the LVOT diameter in real time. You're in parasternal long axis. Freeze your image and you can cine back to where you can see where the valves are open in mid-systole. And we're going to choose our LVOT diameter function here. Place our cursor at the base of the hinges. Slide your cursor over to the base of the other aortic hinge and then tap again and you get a measurement that pops up here. Store that image before going over to measure your VTI. In step 2, as we learned how to measure, you're obtaining your LVOT VTI and getting the heart rate. So again, our apical 5-chamber view, our pulse wave gate is over the LVOT and our Doppler angle is parallel to flow. We'll get our VTI tracing here and making sure we also get the heart rate in that calculation. And just a quick point about LVOT and VTI data. Remembering that the LVOT VTI measures the length of blood flow in the LVOT or left ventricular outflow tract during a heartbeat, which reflects the stroke volume. An average LVOT diameter typically ranges from 1.6 to 2.4 centimeters, and the normal range for LVOT VTI is anywhere from like 18 to 22, can also be 15 to 25 depending on the source. Remembering here that with VTI data, we are tracking a change over time, not just the initial number. So now we can put all of these calculations together that we've learned so far and measure the cardiac output. all we need is the LVOT diameter and the LVOT VTI. So starting by measuring the diameter, and then your ultrasound machine will plug this into a formula to generate the LVOT area. And once we have the area, we now calculate the LVOT VTI, which we learned how to do in our previous video. And now all we have to do is plug and chug some of these numbers and we can calculate stroke volume as well as cardiac output. The good point being about the LVOT diameter is that it can be considered constant and measured once to estimate cardiac output without needing repeat measurements. So without significant variation in heart rate, the VTI alone can be used as a surrogate for cardiac output. So I know that was a lot of information, a lot of different calculations. Hopefully you find the slides and the videos helpful and can play back as many times as you need. And really, hopefully taking away from this lecture that POCUS helps us avoid blind fluid administration and its complications, and that we integrate multiple findings, lungs, IVC, heart, and VTI, and use dynamic tests whenever possible. We always look at the lung ultrasound assessment for fluid tolerance. We look at the echo as a global assessment of the heart function. We look at the IVC variation to give us supportive context. And now we have these new fun tools, the VTI and carotid flow time, and adding a passive leg raise to assess fluid responsiveness. But again, POCUS doesn't replace clinical reasoning, it is meant to strengthen it. POCUS helps us make physiology-based resuscitation decisions. And it can help us identify cardiac or pulmonary limitations that might prevent us from giving fluids, and it helps us avoid over-reliance on a single metric. Here are a couple slides of my references that I used. And again, thank you for tuning in, and hopefully you found this lecture informative and can utilize this in your practice.